Hello, everyone. My name is Anju Nohria, and I am a cardiologist. I direct the Cardio-Oncology program at Dana-Farber Cancer Institute and Brigham and Women's Hospital in Boston, Massachusetts. And today I am going to talk to you about cardiac complications of cancer therapy, primarily affecting survivors, but I will also briefly mention problems that occur in people undergoing active cancer therapy. So with that, I would like to now share my screen. So the topic I was assigned was I had cancer. Now I have to worry about my heart. These are my disclosures. Heart disease is the #1 killer in the United States, and this is true for both men and women, and it is followed closely by cancer. As cancer treatments improve, the number of cancer survivors is increasing in the United States. Currently, there are about 17 million survivors, and this number is expected to increase to 25 million by the year 2020. And as you can see, not only are more people surviving their cancer, but as can be seen in these bars, more and more people are living longer after their original cancer diagnosis. Therefore, we have to worry about the long-term consequences of cancer therapy in terms of long-term toxicities. If we look at the different causes of non-cancer related death in cancer survivors, you can see here that heart disease, shown in red, and cerebrovascular disease, shown here in the maroon, are by far the largest causes of death in cancer survivors. Why is this the case? So partly it's because both cancer and heart disease share several risk factors. Both are diseases of the aging population. As you get older, your incidence of both cancer and heart disease goes up. Tobacco is a common risk factor, for instance, for lung cancer, renal cell carcinoma, and also for heart disease. There are several viral infections that can increase your risk for both cancer and heart disease. We all know that a diet that is low in fiber can also promote diseases such as colon cancer and also can promote heart disease. Certain drugs and alcohol can increase your propensity for both problems. Obesity is a risk factor for several cancers, such as breast cancer, colon cancer, and also for heart disease. Similarly, physical inactivity can also promote your risk for obesity and also for heart and cancer disease. There are several environmental factors that we don't fully understand that clearly contribute to the increased incidence of both these diseases. And then there are genetic factors that can also predispose us to both cancer and heart disease. And one such genetic factor that is currently being studied and is a hot topic in science is something called CHIP, or clonal hematopoiesis of indeterminate origin. This is essentially mutations that you acquire during the course of your life. And these have been shown to increase your risk of developing hematologic malignancies or blood cancers, and also increasing the risk of ischemic heart disease or coronary artery disease. In fact, it has been shown that if you follow the 7 steps of a heart healthy lifestyle, namely you stop smoking, you become active, and by this it means that you should do at least 150 minutes of physical activity a week. You control your cholesterol, manage your blood pressure, and keep it to less than 130/80. Eat a healthy diet that is high in grains, fiber, and nuts. Lose weight and try to keep a BMI that is between 20 and 25, and maintain your blood sugar or prevent yourself from having diabetes. Not only do you reduce your risk of developing heart disease, but the more of these steps you can follow, the lower your likelihood of developing new cancer. So again, living a heart healthy diet not only reduces your risk of having heart disease, but also reduces your risk of developing cancer. But the main topic that we wanted to discuss today was the fact that many cancer therapies can increase your risk of heart disease in several ways. We know that many cancer therapies can promote your risk for developing ventricular dysfunction or weakness of the muscle of the heart. The most important culprits are anthracyclines such as doxorubicin, daunorubicin, epirubicin, or mitoxantrone. Several HER2 blockers such as Herceptin, and then lately newer drugs such as TDM1 and HER2 can also increase your risk for developing cardiomyopathy or weakening of the heart muscle. Drugs such as MEK inhibitors that are used to treat melanoma can weaken the heart muscle. Drugs such as osimertinib that are used to treat certain lung cancers, and then immunotherapy, which is a growing area of cancer therapy, can also lead to myocarditis and weakening of the heart muscle. Other therapies such as tyrosine kinase inhibitors and primarily VEGF inhibitors, drugs such as Avastin, and many of the other drugs that are used to treat renal cell cancer, GI cancers, etc., can increase your risk for developing hypertension. And if you don't control the hypertension, this over time can lead to increased risk of atrial fibrillation, heart failure, kidney dysfunction, etc. So again, if you're taking these drugs, you have to control the blood pressure to prevent long-term consequences of these medications. Proteasome inhibitors such as carfilzomib, which is used to treat multiple myeloma, can also increase your risk of developing high blood pressure. The third category of cardiac side effects is ischemia or coronary artery disease leading to either angina or heart attacks. Certain drugs such as 5-FU or capecitabine or Xeloda, which are often given to treat colon cancer or pancreatic cancer, can cause coronary vasospasm and cause problems on that basis. CML or chronic myelogenous leukemia has drugs such as nilotinib and ponatinib, which can also increase your risk of developing heart disease. Chest radiation, which is a long and old therapy, can lead to delayed consequences, including accelerated coronary artery disease. And then certain immunomodulators like thalidomide, Revlimid, or pomalidomide that are used for maintenance therapy in multiple myeloma can also increase your risk of developing arterial clots. And then there are a newer class of drugs, namely the Bruton tyrosine kinase inhibitors, such as ibrutinib, that are used to treat CLL, etc. And these have been shown to increase your risk of developing arrhythmias such as atrial fibrillation. Some other drugs, such as cisplatin and crizotinib, that are often used to treat lung cancer, can cause slow heart rhythms or bradycardia. Immunotherapy can also cause bradycardia. And radiation can cause atrial fibrillation and complete heart block and increase your risk of needing a pacemaker. And we all know that cancer itself is a disease that promotes clots within the blood vessels, primarily in the venous system. And you can get blood clots in your legs that can then migrate to the lungs and cause a pulmonary embolism. But in addition to cancer, certain cancer therapies like tyrosine kinase inhibitors, immunomodulators, and endocrine therapy like tamoxifen or aromatase inhibitors can also increase your risk of developing venous clots. So with this as a broad overview, I thought I would talk about a few patients that I had seen and highlight some of the major toxicities that you have to worry about in cancer survivorship. So FA was a 63-year-old woman with triple positive breast cancer that was diagnosed in 2006. She initially had a radical right mastectomy, and she was given chemotherapy consisting of 5-FU, epirubicin, and cyclophosphamide. She also received radiation to the right chest and Herceptin therapy that was continued for 1 year. Unfortunately, about 13 cycles into her Herceptin therapy, she had an echocardiogram that showed that her heart function had decreased to 45%. Normal cardiac function is usually in the 55 to 65% range. At that point, she was almost nearing the completion of her Herceptin therapy, so her doctors decided to truncate it a little prematurely, and they transitioned her to letrozole, which she continued for the next 5 years. She was cancer-free until 2014, but unfortunately, she developed metastatic disease affecting the bones and the lining of the lungs. At that point, her cardiac function had improved, and she was treated with a short course of paclitaxel, Herceptin, pertuzumab or Progetta, and unfortunately, a month into her treatment, she developed worsening cardiac function and her ejection fraction had decreased to 35%. So she received several drugs that can lead to weakening of the heart muscle. The first such drug was the epirubicin, which belongs to a class of medications known as anthracyclines. More commonly in the US, patients receive doxorubicin, and epirubicin is used more commonly in Europe. So as you can see from this graph, anthracyclines cause a dose-dependent toxicity, meaning the higher the dose you get, the higher the likelihood of developing cardiac dysfunction. Most patients who get anthracyclines for breast cancer get about 240 milligrams per meter squared. And patients who get anthracyclines for lymphoma, either Hodgkin's lymphoma or non-Hodgkin's lymphoma, tend to get between 250 and 300 milligrams per meter squared of anthracyclines. At these doses, about anywhere from 5 to 9% of patients will develop an asymptomatic decline in their cardiac function, and about 2% will go on to develop symptomatic heart failure. The other drug that she got that can cause weakening of the heart muscle is trastuzumab or Herceptin. This is a drug that does not cause a dose-dependent cardiomyopathy, but you can develop cardiomyopathy anytime during your treatment. Most patients who get this drug for breast cancer get it for about a year, and you really have an equal likelihood of developing it anytime during that 1 year. Other diseases for which this is often used is things like esophageal cancer, etc., where you can have HER2 positive cancers as well. And many people who have metastatic disease that is HER2 positive can get lifelong therapy with these agents. So you have to be prudent about looking for the development of cardiac dysfunction throughout their treatment course. In general, clinical trials have shown that about 13% of patients getting these agents develop an asymptomatic decline in their cardiac function, and about 2% go on to develop symptomatic heart failure. However, if you catch this early, often if you withhold the drug, the heart function will return to normal. And particularly if you start them on cardiac medications, the heart function can in fact return to normal, and many of them can even retolerate challenging themselves with the drug again and continue on the drug on the background of cardiac medications to be able to complete their therapy for the inevitable future with close monitoring. There are many newer forms of HER2 blockers that are out there in the market. Some of the drugs that are used are pertuzumab and lenvatinib. These are rarely given by themselves and are usually given in combination with Herceptin. It doesn't appear that the combination is any more cardiotoxic than receiving Herceptin by itself. Some of the newer agents that are out there are drugs such as TDM1 and Enhertu. What these are trastuzumab conjugated to another chemotherapy agent, such that you have to use less trastuzumab and you have more targeted killing of the cancer cell by this accompanying chemotherapeutic agent. At least in early trials, the cardiotoxicity associated with these agents is less than that seen with Herceptin, but they have not been in the market long enough to have really good data regarding the incidence of cardiotoxicity with these drugs. But often if you have someone who needs lifelong therapy, for instance, for metastatic disease, and their cardiac function is borderline or a little bit depressed, you can consider giving them these drugs instead of Herceptin to try and lower their risk of developing cardiotoxicity during the course of their treatment. So what are the classic risk factors for cardiotoxicity? As I mentioned to you before, the higher the dose of anthracyclines, the higher the likelihood of developing cardiotoxicity. And usually we consider a doxorubicin dose greater than 250 milligrams per meter squared to be cardiotoxic, or any dose of epirubicin exceeding 600 milligrams per meter squared is also considered to be cardiotoxic. High dose chest radiation, upwards of 35 gray, is also associated with long-term cardiotoxicity. If you get combination therapy with anthracyclines and chest radiation, particularly left-sided chest radiation, since the heart is on the left side of the chest, is cardiotoxic. Anthracyclines followed by trastuzumab or Herceptin is also felt to be cardiotoxic. And in our patient's case, she had received anthracyclines in 2006, followed by trastuzumab, and now got additional trastuzumab. So this alone places her at high risk. If you are over 60 years old at the time of treatment, if you have other cardiovascular risk factors such as hypertension, hyperlipidemia, diabetes, all of these increase your risk further. And if you have received any dose of anthracyclines or trastuzumab and have pre-existing cardiovascular disease, such as a borderline cardiac function, more than moderate valvular heart disease, or a prior heart attack, all of that puts you at higher risk for developing chemotherapy-induced cardiac dysfunction. So what do we recommend you do to prevent cardiotoxicity? So first of all, when you are diagnosed with cancer, your doctor should assess your cardiac risk factors and make sure that your blood pressure, cholesterol, and sugars are adequately controlled. They should get a baseline echocardiogram to assess your cardiac function and make sure that you don't already have a weak heart, which would be further weakened by getting potentially cardiotoxic therapies. During cancer treatment, every time you go to the doctor, they should be checking your blood pressure, etc., to make sure that it's adequately controlled. If you are in the high risk category, either because you have pre-existing disease, you're getting combination therapy or high dose anthracyclines or radiation, they should think about putting you on cardioprotective medications such as an ACE inhibitor or a beta blocker. Or if you're someone who needs really high dose cancer therapy, they can give you a drug called dexrazoxane along with your anthracyclines, especially if you're receiving doses above 300 milligrams per meter squared. And this has been shown to lower your risk of cardiotoxicity. Unfortunately, dexrazoxane does have some toxicity of its own in terms of lowering your white counts, etc. So we don't give it to everybody, but only to select patients in whom you have to get very high dose therapy, such as if you have sarcoma or recurrent lymphoma, etc. In general, while you're being treated, your doctor should ask you about cardiac symptoms such as chest pain, shortness of breath, etc. And you should get an echo if you're getting anthracyclines after you've received 250 milligrams per meter squared. And if you're getting higher doses, you should get an echo after every 50 or 100 milligrams thereafter. If you're receiving Herceptin, the guidelines state that you should get an echo every 3 months while you're getting trastuzumab therapy. If you have metastatic disease and your cardiac function has been relatively stable, sometimes the doctors can push that interval out to 6 months, or in some cases, even out to every year. In general, once you have finished completion of your chemotherapy, you should have a continued periodic assessment of your cardiac risk factors, and they should be modified. Your doctor should be looking for cardiac symptoms. In the case of anthracyclines, most people who develop cardiac problems do so within the first year after completing therapy. So the guidelines state that you should get an echo 6 to 12 months after completing therapy, because that is the biggest bang for the buck to find a problem. And if you catch it early and intervene, you can often improve the cardiac function. For people who received anthracyclines followed by trastuzumab or Herceptin, we recommend getting an echo again 6 months after completing therapy to make sure that you capture majority of the people who go on to develop cardiac dysfunction. If you are a childhood cancer survivor, meaning that you were treated before the age of 21, the Childhood Oncology group has very strict guidelines about how you should be screened, and the frequency of screening with echocardiograms depends upon the dose of anthracyclines you received and whether or not you received chest radiation with that, and within chest radiation, whether you got low dose, moderate dose, or high dose chest radiation. If you got high dose anthracyclines, you should be getting an echo every 2 years for the rest of your life. If you received high dose radiation, you should be getting an echo every 2 years for the rest of your life. If you received any combination of low-dose anthracyclines or low-dose radiation, you should get an echo every 5 years. If you received intermediate doses of radiation alone, you should get an echo every 5 years. And if you received very low-dose radiation alone without anthracyclines, you do not require any further screening. One area of particular interest in childhood cancer survivors is childhood cancer survivors who are deciding to become pregnant. Again, if you are deciding to become pregnant, you should get an echo at baseline. And in particular, an echo should be done in anyone who is at high risk, meaning that they got a high dose of anthracyclines, they were below the age of 5 when they were diagnosed with cancer. The longer the time elapsed from cancer treatment to pregnancy, the higher risk of having cardiac problems, particularly if you received chest radiation. And then if you are currently on heart medications suggesting that you have underlying cardiovascular risk factors, again, that places you at higher risk for having complications from your prior chemotherapy. If your cardiac function is normal, you're at low risk for having cardiac complications during pregnancy, and your risk of heart failure is less than 1%. So really, you just should get routine pregnancy care, and they should be looking out for cardiac complications, but you don't need any routine screening during your pregnancy. If your cardiac function is not completely normal, i.e. it's borderline or a little bit low, you really should be seen by cardiology, and they should plan for surveillance during your pregnancy. And the reason is that as you enter at the end of your second trimester or the beginning of your third trimester, your blood volume more than doubles, and that puts a lot of load on the heart. And if your heart is weak, it can weaken further, and you can go on to develop symptomatic heart failure. So your doctors will usually recommend getting an echo in the beginning, and then again at the end of your second trimester, beginning of your third trimester, to make sure that your heart has not weakened further with the pregnancy. You should be followed by a high-risk pregnancy group, such as a maternal fetal medicine OBGYN. You shouldn't be seen by somebody out in the community. You should not consider having a home birth. You should really give birth in a hospital. And again, people should be doing cardiac monitoring during labor and delivery to make sure that you can tolerate this without significant problems. If you already have cardiac dysfunction or heart failure before you become pregnant, you really should consider not becoming pregnant, because your risk of having significant heart failure during pregnancy is almost 30%. So what happened to our patient? So she had several cardiac risk factors that were poorly treated. Her blood pressure was 148/89, and an ideal blood pressure is less than 130/80. She was a little bit overweight with a BMI of 32.9. Her lipids were elevated with a total cholesterol of 259, normal being less than 200. Her LDL cholesterol was elevated at 183, ideal being less than 100. Her diabetes was well controlled, and she was relatively inactive and had a poor functional capacity on a stress test. So based on these things, we started her on blood pressure and cholesterol lowering medications. We enrolled her in a cardiac rehab program, and over the next year, her cardiac function eventually returned to normal. Her doctors did not give her any further cardiotoxic therapies, and instead started her on drugs that did not have any significant cardiac side effects. She did well for the next 3 years, but unfortunately, her disease ultimately progressed and she died with hospice care in 2018. So now the second big toxicity that we see is that associated with chest radiation. So I thought I would talk about patient JD. He's a 52-year-old man who received treatment for stage 2B Hodgkin's lymphoma at the age of 19. He received treatment with anthracyclines, bleomycin, vincristine, and dexamethasone, and he also got mantle radiation. His total adriamycin or anthracycline dose was about 300 milligrams per meter squared. So again, this was high dose, and his mantle radiation dose was 36 gray, which was also high dose. So this is a patient who is at high risk for developing cardiac complications later in life. He was active with no other cardiac risk factors, and one day he went to dinner with some friends and suddenly fainted without any warning. 1 month later, he noticed that he was getting more and more short of breath and lightheaded with any activity. And he called me one day saying, I tried to walk my dog around the block and I had to stop and come back home because I couldn't catch my breath. I brought him to my clinic, and his EKG showed that he was in complete heart block with an escape rhythm of 40 beats per minute. He underwent an urgent pacemaker, and a subsequent cardiac catheterization showed he had a 90% blockage in the main blood vessel of the heart, known as the left anterior descending artery. So we immediately performed an angioplasty and he underwent a drug-eluting stent placement. He did well for 2 years, and 2 years later, he came in with recurrent shortness of breath and lightheadedness. An echo now showed severe mitral regurgitation. His mitral valve was leaking, and he also had tightness or constriction of his aortic valve and had moderate aortic stenosis on an echocardiogram. So we know that if you receive chest radiation, particularly for Hodgkin's lymphoma, your risk of having radiation-induced heart disease is about 6-fold higher than that of other age-matched, non-radiated individuals. Your risk for having coronary artery disease prematurely goes up by about 5-fold. Your risk for having valvular heart disease, either leaky valves or tight valves, and primarily the aortic and mitral valves, which are the left-sided heart valves, are involved the most, followed by the tricuspid valve, which is located on the right side of the heart. About 2-fold higher risk of requiring pacemaker placement for complete heart block. You have about a 5-fold higher risk of developing heart failure, either as a result of coronary artery disease, valvular heart disease, or because of stiffening of the heart muscle. And then you have about a 2 to 13-fold higher risk of dying from a cardiac cause compared to other individuals. If you receive radiation for breast cancer, particularly to the left breast, your risk of ischemic heart disease goes up, but you don't tend to have a risk for any of the other complications, such as those seen if you get radiation for Hodgkin's or non-Hodgkin's lymphoma. Of course, realizing this, the radiation community has made many changes to try and limit cardiac exposure. They now routinely shield the heart if the tumor is not overlapping with the heart. They try to minimize the radiation dose to the heart by putting people in a prone position. They use tangential beams. And there are also newer radiation techniques such as proton beam therapy, etc., that reduce the amount of penetration of cardiac tissues and thus reduce the risk for developing long-term cardiac complications. Unfortunately, it takes about 10 to 20 years to manifest the effects of radiation on the heart, and therefore we currently don't have data to show how much less the adverse effects are from these newer radiation techniques. Again, like anthracyclines, radiation has a dose-dependent effect, and for every every 1 gray increase in radiation dose to the heart, your risk of coronary artery disease goes up by 7.4%. So again, that is why people are working really hard to try and limit the amount of radiation dose to the heart going forward. How to prevent and diagnose radiation toxicity? Again, cardiac risk factors increase your risk beyond what the radiation imposes. You have no control over the requirement for radiation, but you can control your other cardiac risk factors such as blood pressure, cholesterol, and diabetes. So again, work hard on trying to have your doctors look for those cardiac risk factors and modify them appropriately. You should pay attention to any cardiac symptoms such as chest pain, shortness of breath, lightheadedness, and bring them to the attention of your doctor. The guidelines recommend that 5 to 10 years after completing radiation therapy, you should get a surveillance echocardiogram and a stress test, and this should be repeated every 5 years thereafter. Obviously, if you have any concerning symptoms, you should bring them to the attention of the doctor, and they may test you sooner if indicated. In general, radiation patients do not do as well with cardiac surgery as non-radiated individuals. In this picture, you can see the solid lines. The first solid line is a non-radiated individual having surgery for the first time, and this is their survival over time. The dotted line here shows you a radiated individual having surgery for the first time. And as you can see, their survival is much less than that for someone who did not receive radiation therapy. Why is this the case? So radiation not only affects the heart, but also affects the lungs and the chest wall. So many people who've received high-dose radiation to the chest also have lung disease, which can give them pneumonia. It can make it difficult to extubate them. They can have pleural effusions or fluid between the lining of the lungs and the lung that can take a long time to drain, all of which increases your risk after having cardiac surgery. The fibrosis of the chest wall can lead to poor healing. And again, as I mentioned, many of these patients will have coronary artery disease, valvular heart disease, a stiff heart, all at the same time. And therefore, the surgeries tend to be longer. And also the healing process for the heart tends to be less good because the heart has so many problems that it has to deal with. Similarly, if you have redo surgery, even for non-radiated people, redo surgery has a higher risk than first-time surgery, and in radiated patients, that is true to an even larger extent. So in general, nowadays, luckily, technology has made a lot of non-surgical interventions possible for cardiac problems. We have angioplasty instead of bypass surgery for people who may have single or double vessel disease. In general, if you have three vessel disease or left main disease, cardiac surgery is still the preferred option. Now you can do aortic valve replacements via a percutaneous approach or a catheter-based approach. So often if you only have aortic stenosis or aortic regurgitation, you do not need to have surgery. Mitral valves do have upcoming percutaneous or catheter-based approaches, but still if you have mitral disease, you may require surgery. Hopefully this will change within the next few years. If you do have to have surgery, make sure that you go to a center that is familiar with radiation heart disease and has surgeons who understand all the complications and nuances of this problem. Many patients can have a calcified aorta, which is the main blood vessel that goes from the heart to the rest of the body. And often this can be complicated if you are being put on bypass. So in most centers that are familiar, they will do a CAT scan or something to evaluate your aorta and make sure that you can be cannulated from the aorta for bypass. You should have some sort of evaluation to make sure that you don't have severe radiation-induced lung disease. And because you don't want to have a reoperation, you should make sure that if you have a moderate problem in your coronaries or a moderate problem in another valve, that they should fix all of these things at the same time to avoid the need for redo surgery. So what happened to our patient? He was evaluated for a catheter-based mitral and aortic valve replacement. Unfortunately, his mitral anatomy was not suitable. He underwent surgery for aortic and mitral valve replacement. He had a little bit of heart failure after the surgery and required IV diuretics. His chest tubes were in for a little bit longer because the pleural effusions took a while to get better, but eventually he recovered and currently is doing very well. So lastly, this is not a survivorship issue, but more an issue of ongoing therapy, but I wanted to talk about immune checkpoint inhibitors. These are revolutionary immunotherapy that is now being used to treat many solid tumors that previously had a very poor prognosis. These are drugs that basically rev up your own immune response against the tumor, and they allow you to kill the tumor more effectively. But because you're revving up the immune response, you can also get autoimmune problems against other bystander organs in your body, and the heart is no exception to that. So this is patient MW. She was a 70-year-old woman who had metastatic lung cancer and was being treated with the checkpoint inhibitor pembrolizumab, which is also known as Keytruda. 2 months into her treatment, she presented with bilateral drooping of her eyelids and diffuse muscle weakness. Her labs showed elevated muscle and cardiac enzymes. So, immune checkpoint inhibitors can cause several forms of cardiotoxicity. The Your own immune system can attack the muscle of the heart, giving rise to myocarditis. It can affect the lining of the heart, giving rise to something called pericarditis, which can be accompanied by fluid outside the heart or a pericardial effusion that can restrict the function of the heart, and often this fluid has to be drained. You can also get conduction system disease requiring pacemaker placement. You can get blockages within the coronary arteries requiring intervention. And then you can also get a ballooning of the heart leading to weakness of the heart muscle. I would like to stress that this complication is extremely rare. It happens in less than 1% of patients, but if it happens to you, about 50% of cases can be lethal unless they're caught and treated appropriately. The risk is higher if you get dual checkpoint inhibitor therapy, often with drugs such as ipilimumab and nivolumab, or ipilimumab and pembrolizumab, and is less frequent if you get only one immune checkpoint inhibitor as cancer therapy. How do you manage this? Your doctors will usually immediately stop the immune checkpoint inhibitor if you have any cardiac symptoms or signs of cardiac injury, such as in our patient. You want to check the cardiac biomarkers in the blood, namely troponin or NT-proBNP. You check an EKG. You look for a cardiac MRI, which shows whether the heart is swollen or damaged, and it also tells you how well the heart is functioning. You can also look to see whether there is inflammation within the heart or in the heart lining. And often, if the cardiac MRI is not definitive or the EKG is not definitive, but you have enough of a concern that the patient may have it, we will recommend doing a cardiac biopsy, primarily to look for immune cells within the heart muscle. And if you see them, that is the gold standard way of diagnosing checkpoint inhibitor-induced myocarditis. The treatment is that you stop the checkpoint inhibitor and immediately start very high dose steroid therapy with prednisone or sometimes IV solumedrol. And then you taper this very slowly over several months based on your symptoms and cardiac labs. In often, some people will have persistent elevation of their cardiac labs and or symptoms, and they may need additional immunotherapy. And in general, if you've had this complication, we recommend that you not resume an immune checkpoint inhibitor in the future. So what happened to our patient? Her pembrolizumab was stopped and she was started on high-dose steroids. She was seen by neurology and they diagnosed her with a disease called myasthenia gravis, which you can see with checkpoint inhibitors, and skeletal muscle myositis. Her cardiac MRI was negative, so we sent her for a cardiac biopsy that luckily did not show cardiac involvement. And therefore, her steroids were able to be tapered more rapidly. And her therapy was changed from immunotherapy to something else by oncology. So the take-home points, if there's one thing I can stress, it is that maintaining a healthy lifestyle not only helps reduce your risk of cardiovascular disease, but also reduces your risk of cancer. Having underlying cardiac risk factors such as hypertension, hyperlipidemia, and diabetes can lead to worsened cancer outcomes, one, by increasing your risk of cardiac events that limit your ability to receive successful cancer therapy, and also these increase your risk of cardiovascular toxicity down the road from certain cancer therapies. What can you do as a patient to advocate for yourself? Insist on your doctors checking your cardiac risk factors and correcting them according to the guidelines. Namely, you should have a blood pressure that is less than 130/80. You should have a hemoglobin A1C that is less than 7 if you have diabetes. And you should ideally have a total cholesterol less than 200 and an LDL less than 100. And if you have known coronary artery disease, your LDL should be less than 70. And again, correction of these risk factors and continued surveillance improves your cardiac function and gives you the best chance of having good outcomes from your cancer therapy. Thank you for your attention.